Hi, my name is Donna Simpson. My presentation is about intramuscular injections in children. How should intramuscular injections be given to children? We all know that injections are painful. They cause anxiousness and fear, even preventing some from going to the doctor. Injections hurt. They are scary. You need to have a knowledge of anatomy and physiology in order to give an intramuscular injection. Care should be taken to relieve a child's anxiety and pain during injection. My research is gathered from the CNAL database. I ruled out articles relating to adults, diabetes. I included 7 articles that related to injections given to children between the ages of 0 and 18. Some of the studies were quasi-experimental, a case study, a meta-analysis. Some were random and some were convenience. Many involved the use of clinics. The first article was about improving the pediatric experience of pain during vaccinations. It was a quality improvement product. It compared the use of topical anesthetics and sucrose. The board determined that it was unethical to not offer these, and so therefore there was no comparison group. Pain was scored according to a face-leg pain scale. Sucrose and analgesics were rarely used. Clinicians knew about them, but they did not always use them for the children. Further studies should be done about the use of toys, bubbles, and distraction techniques. Another article, Effectiveness of Pre-Cooling the Injection Site with Tetrafluorine on Pain Perception in Children. It involved a bilateral study of children that were removing teeth on both sides of their mouth. Prior to giving the shot, on one side, the dentist just provided a topical anesthetic. On the other side, they used a coolant spray, which was done 2 weeks after the first time. The children seemed to prefer the coolant spray. It relieved more of their pain, as related by their assessment with the visual analog scale, and as the clinician's assessment related to sound, eye, and motor, the SEM scale. The coolant spray did not have a bad taste. It stayed in the correct spot, and it was fast acting. The other article on Aboriginal children with penicillin injections for rheumatic fever talks about children that had to come back monthly for injections. 4 clinics were studied in Australia. 52 clinicians and 52 children were interviewed and observed. Staff did inconsistently apply the techniques for pain relieving. Some of the techniques they did apply were to administer slow. They recommended pressure, a topical anesthetic, and a vibrating cooling device. The Buzzy Bee, which is a cold vibrating technique, was often applied prior to the injection site and helped relieve the pain and anxiety. The nurse needs to look at, being that these are returning children, the nurse should be asking the children what preference they would have to help relieve their pain during their injection. A meta-analysis was done of 23 studies about pain perception in children with immunizations. It was found that topical anesthetics help some, coolant spray helps, but Emla cream seemed to be the best thing in decreasing the pain perception in injections in children. Also, ibuprofen can be used prior to their arrival. Emla cream was effective in reducing the pain, but it does have a cost of about $12 per injection. Pain relieving techniques need to be used more consistently with children. Shots can be given in the deltoid and in the thigh. The articles did not recommend giving shots in the buttocks where the needle could hit the nerve and cause major damage or an artery. Complications were nerve damage, reaction, necrosis, and cellulitis. Further research should be done with the Buzzy Bee, the vibrating cold, seeing if that could further reduce the pain associated with injections in children.